Hello everyone and welcome back. We have discussed the multiple gestation in the last video, and in this section we are going to discuss the puerperium and puerperal pyrexia. So there is a para 3 presents 4 days after the delivery with fever and offensive lochia. So what is the diagnosis and the definition and the postnatal investigations for neonate? Another scenario is that there is a P3 with NVD at home and 7 days ago came with high fever, palpitations, BP and temperature, tender lower abdomen is present. Okay, so let's define the puerperium first. It refers to the 6 weeks period following childbirth, and it begins after the delivery of placenta and lasts until the uterus have returned to their pre-pregnancy state. This is puerperium. The uterus of 1 kg is reduced to 100 gram during these 6 weeks, and immediately after the delivery, the uterine fundus lies about 4 cm below the umbilicus, or more accurately 12 cm above symphysis pubis. However, after 2 weeks, it's not palpable at the symphysis pubis as involution occurs by the process of autolysis and the cells gets back to the normal size. The physiological changes in puerperium are uterine involution, genital tract changes, and lochia, and the failure of involution occurs due to fibroid, retained placental tissues, full bladder, broad ligament hematoma, uterine infection, and loaded rectum. These are the causes. Okay, now what is puerperal pyrexia? It is defined as the fever of 38 degrees C and 100.4 degree Fahrenheit for consecutive 2 days during first 10 days of the puerperium. Now the causes are throat infections, mastitis, UTI, any wound infections, genital tract infections, DVT, and infection in the abdomen. And the retained products of the conception are also the causes of puerperal pyrexia. Now the genital tract causes are the causes of infection, C-section, instrumental delivery, retained products of conception, vaginal cervical lacerations and prolonged rupture of the membrane, manual removal of the placenta, and antenatal infections. The non-obstetrical causes are obesity, steroids therapy, and diabetes mellitus and genital tract infections. The complications are tubal blockage, infertility, shock, septicemia, artificial rupture of membrane, and DIC and PIDs. The clinical features are symptoms and signs. The symptoms are fever, paralytic ileus that is presenting vomiting, fever, pain in abdomen, and the symptoms of secondary PPH, offensive vaginal discharge, and pain in calf muscles. The signs are increased pulse, tachycardia, lethargy, breast tenderness, enlarged breast, boggy soft uterus, and peritonitis. Now, the investigation options are blood count, that is HB, TLC, platelet count, increased WBC, and decreased platelets. The blood and uterine culture are vaginal swab, intrauterine swab for clinical examination. RFTs and serum electrolytes are done. Coagulation profile is done for DVT diagnosis on Doppler ultrasound if associated with embolism present with. The risk factors are DIC, shock, ARF, and sepsis and PID. Now the management is done. First of all, stabilize the patient. That is reassurance to relieve the maintain stress. Then BP, pulse, and monitoring is done. Intravenous fluids and plasma expenders are given. Analgesics and antipyretics are given. Blood transfusion is done if HB is very low. The specific treatment is catheterize the patient. If urinary retention is present, broad spectrum systemic antibiotics in high doses are given. Intravenous antibiotics like metronidazole, ceftriaxone to protect against the infections, and monitor for complications like DIC, ARF, sepsis, and DVT. For DVT treatment, heparin is given. For septicemia, broad spectrum antibiotics are given. Check for predisposing factors like retained placenta, and in case of retained placenta, remove placenta, do evacuation of the uterus. In case of wound infection, pus may be surgically drained. For mastitis, do the hot fermentation, and for infection of the skin because of episiotomy, give antibiotics. Now, the prevention of puerperal pyrexia is done is improve the genital hygiene, good surgical approach, prophylactic antibiotics, and use of aseptic techniques, intraoperative single dose of antibiotics after clamping the umbilical cord. So this was about puerperium, that what is puerperium and what is puerperal pyrexia. Then we have defined the puerperal pyrexia, that it is fever of 38 degrees C for consecutive 2 days during the first 10 days of puerperium, and the causes are the throat infections, the mastitis, the UTI, the wound infections, the genital tract infections, the DVT, and the infections in abdomen. Then we have genital tract causes and non-obstetrical causes, then the complications, the clinical features which are symptoms, and investigations and risk factors. Then we have discussed the management, that is stabilize the patient, then specific treatment is given. And Okay, specific treatment is given, and then the prevention of the puerperal pyrexia, improved genital hygiene, good surgical approach, prophylactic antibiotics, use of aseptic techniques. All these are the prevention of puerperal pyrexia. Now coming towards the next topic, that is episiotomy. So what is episiotomy defined and what are the different types and its complications? Okay, so episiotomy is a surgical incision through the perineum made to enlarge the diameter of the vulval outlet and assist childbirth during the second stage of labor. Now, the indications for episiotomy are tight outlet, previous pelvic reconstructive surgery, shoulder dystocia, breech delivery, instrumental delivery, fetal distress, macrosomia, delayed second stage of labor, preterm labor, and perineal scar. The advantages of the episiotomy are that it prevents fetal brain injury, preserves integrity of the pelvic floor, prevents uterine prolapse or descent, prevents rupture of the vesicovaginal septum, and the disadvantages are hemorrhage, extension of episiotomy, hematoma formation, pain, infection, urinary retention, Bartholin cyst formation, shock, and perineal tears. Now, the types of episiotomy are midline, lateral, mediolateral, and J-shaped episiotomy. Midline is the incision in a comparatively avascular area. The incision commences from the center of the foresheted and extends on the posterior side along the midline for 25 cm. The advantages are less bleeding, quicker healing, and less pain. The disadvantages are increased risk of extension to involve the anal sphincter. Now, mediolaterally, incision made at the posterior part of the foreshead, more backwards, and then medially well before the border of anal sphincter, so that any extension will miss the sphincter 2.5 cm away from the anus. The advantages are that it does not cause the third and fourth degree tear, and the disadvantages are that the blood loss is more and bad healing and not easy to repair. Now, the J-shaped incision, this is the incision begins in the center of the foreshead and is directed posteriorly along the midline for about 1.5 cm and directed downwards and outwards along the 5 or 7 o'clock position to avoid internal external anal sphincters. This incision is not widely practiced. The methods of episiotomy. First of all, take the informed consent. Then episiotomy is performed in second stage, usually when the perineum is being stretched and it is deemed necessary. If there is not good epidural, apply local anesthesia, that is 1% xylocaine jelly, and incision is then made, usually mediolateral. After the delivery of the baby, stitch the vaginal mucosa, perineal muscle, and skin. Also, hold of the apex is really important and should not be missed. Visceral thread is used and mucosa is stitched in continuous pattern and are stitched in the interrupted fashion. Okay, so this was all about the episiotomy. First of all, we have discussed the definition that it is a surgical incision through the perineum and it is used to enlarge the diameter of the vulval outlet and assist childbirth during the second stage of labor. Then we have discussed its indications, that it is due to then tight outlet, previous pelvic surgery, shoulder dystocia, breech delivery, instrumental delivery, fetal distress, macrosomia, delayed second stage of labor, preterm labor, and perineal sex. Now, these are the advantages and disadvantages. Then we have discussed the types of episiotomy, which is midline incision and mediolateral incision and J-shaped incision. And the general method for the episiotomy is that first of all, you have to take the consent from the patient, and then episiotomy is performed in the second stage and xylocaine gel is given, incision is made. Usually it is given as mediolateral. This is the most common. Okay, this is the favorite viva questions, that which incision of episiotomy is the common incision. It is mediolateral. After delivery of baby, stitch the vaginal mucosa, perineal muscles, and skin, and also the hold of the apex is really important and should not be missed. And mucosa is stitched in continuous pattern and muscles are stitched in interrupted fashion. Okay, so in the next video we will discuss the perineal trauma or tears and the perineal repair and then the instrumental vaginal delivery. Thanks for watching.